Before we start, I'd like to mention that MIMS Learning Live Digital is coming up in March. This is a virtual learning event spread across 4 evenings from the 9th to the 12th of March, offering live learning and CPD certification. Not to be missed. Book your place today through the link given in the show notes. Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking education from MIMS learning that you can fit into your busy life. I'm Pat Anderson and I'm delighted to have with me today GP Dr. Toni Hazell, who has a particular interest in women's health and who's going to talk to us today about changes to contraceptive guidance. Welcome, Toni.
Hi Pat, thanks very much for having me.
So, Toni, just very quickly, would you like to tell us a little bit about your background in women's health?
Yeah, absolutely. I'm a GP in North London. I've been at the same practice for 20 years and I developed my interest in women's health from quite early on. I did my diploma in family planning, as it was called then. As a registrar, I'm a director of the Primary Care Women's Health Society and I've got a portfolio career with a variety of roles in education. But I'm here today as me rather than on behalf of any of the organisations that I work for.
Brilliant, thank you. So can you just, for people who are not so familiar, just explain what UKMEC is and how it's used?
Yeah, absolutely. So the UKMEC, the UK Medical Eligibility Criteria for Contraception Use, is really the gold standard guidance for safety in contraceptive prescribing in the UK. It's published by the COSRH, the College of Sexual and Reproductive Healthcare. And if people are thinking, oh, I've never heard of them before, this is the body that until November last year was the Faculty of Sexual and Reproductive Healthcare, the FSRH. They changed to become a college. Some of their older guidance still says FSRH on the downloads. The crucial thing about the UKMEC is it's just about safety. So it's not about efficacy of the contraception. It's about how safe it is. And obviously, by definition, medicine is complex. It can't cover absolutely everything. So if a condition isn't mentioned in UKMEC, that doesn't necessarily mean that it's safe to prescribe. You've got to use your clinical judgment. It applies to contraceptive use only. So if you are balancing risks and benefits of a method and the patient is getting a benefit out of it other than contraception, for example, maybe using it to treat endometriosis or some other condition, then that's something on the benefits side which may change your risk assessment of how much the benefits and the risks balance. And within the UKMEC, there are 4 categories. Every contraceptive method for every medical condition that's in there is split into 4 categories. So 1 and 4 are straightforward. 1 is no problem, no contraindications. 4 is an absolute contraindication, do not use. And then 2 and 3 are the relative contraindications. So 2 is, broadly speaking, the benefits will outweigh the risks, and 3 is, broadly speaking, the risks will outweigh the benefits. That doesn't mean that you would never prescribe a UKMEC 3, but it's generally considered that if you are prescribing something that's UKMEC 3, you should probably be someone with some expertise in the area. And if you don't feel as a GP that you have that expertise, then it might be an indication to refer on to a colleague or a specialist clinic. I would expect, for example, that if one of our GP registrars was thinking about prescribing a UKMEC 3, that they might come and talk to us. And I think in some cases, the PGDs used by some members of staff in contraceptive clinics don't always allow prescription of a UKMEC 3.
Right. Oh, thank you for that. That's really helpful. The UKMEC 2025 has key changes. And why are the changes being made to recommendations at this point?
So for such a key document, it doesn't get updated that often because, as you can imagine, it's a massive process to update it. I went to the COSRH conference this year where it was launched and they outlined the process of updating it, and it was a huge long process over months or years. The last one was written in 2016 with a bit of an update in 2019, and things have changed. There's been a lot of new evidence, so basically it was really due for it, particularly new evidence about the Depo-Provera and venous thromboembolism risk that had come up between the last update and now.
Can you talk us through some of the key changes? For example, are there new categories within UKMEC?
Yes, so there's two new categories that weren't there before, and those are multiple sclerosis and chronic kidney disease. So with multiple sclerosis, the risk is mainly due to immobility. So most of the restrictions and relative contraindications are with the group that is largely immobile with their MS, but also patients with MS have an increased risk of fracture, and the depot injection reduces bone density, so there is also a slightly increased risk related to the use of the depot injection if you have MS. And the other new category is chronic kidney disease. So this doesn't cover everyone with CKD. We all have, large amounts of people who have CKD recorded on their notes. That would be quite difficult, but it's the most severe form. So it's people with current nephrotic syndrome or those who are on hemodialysis or peritoneal dialysis for whom they shouldn't use a combined hormonal contraception. That's a UKMEC 4 because of the venous thromboembolism risk. And the depot is a UKMEC 3, and that's to do with the risks of bone health in a population that already have issues to do with bone health.
So does that mean that if you have known patients with MS and chronic kidney disease in the specific category you've described, would you then have to go and review those patients and make sure that they're not on something that's no longer regarded as appropriate?
Yeah, absolutely. It's going to be an interesting thing as to how we all react to this, because obviously it's a big update. It's a huge amount of work to make sure that everyone is on the correct contraception and being prescribed for safely. And it's one thing to make sure when you're starting someone new that you use the new guidelines, but obviously we have a load of people who are on contraception on repeat prescriptions. So practices are going to have to work out how they do that. And it may be a case of doing some searches. I think these two populations aren't huge numbers. We don't have huge numbers of people with MS, and it is only the most severe CKD.
Yeah, so I guess the trawling through records and stuff wouldn't be too onerous, but it's perhaps what kind of urgency do you think there is around doing that process?
It's an interesting question. So thinking around MS, for example, there aren't any UKMEC 4s, so nothing is absolutely contraindicated. MS with prolonged immobility is now a UKMEC 3 for those on combined hormonal contraception. So that's risks outweigh benefits. So that would probably be something worth doing a search on, and the numbers should be small. And then for anyone with MS, prolonged immobility or not, the depot is now a UKMEC 2, which is benefits probably outweigh risks. So I think in any case, a reasonable thing for practices to be doing would be to make sure that everyone who is on the depot, someone just looks through their notes to see if they have changed any categories before they have their next injection. And the depot is given every 12 weeks. So it would mean that over the next few months, everyone would gradually be reviewed. And that could either be picked up with a search, or else, admin team could be asked to look out for when people book in with the nurse for the depot injection. And obviously the nursing team could be aware that if someone comes in for a depot injection, they should just have a quick review of their notes before they give it.
Sure. Thank you. And what other changes are there to UKMEC 2025 within existing categories?
Yeah, so there's quite a few changes within existing categories. And the biggest one is probably for depot, which I've sort of touched on already. So there had a while ago been one or two small studies suggesting an increased risk of venous thromboembolism, VTE, with depot use. But over time, there's been more, and there's now 5 observational studies that have shown that depot use increases VTE risk compared to no contraception. It's generally less risky than combined hormonal contraception, so it's sort of in between the two of background and combined hormonal contraception. And so the COSRH have reviewed, and there's about 10 categories, I think, where the risk level has gone up, usually by 1, so from 1 to 2 to 2 to 3, and they're listed on the COSRH website in their summary of it. That's the single method that has had the biggest number of changes. There's always been the issue of smoking, and when you ask someone about smoking, does that include vaping? Because I think particularly among younger cohorts, maybe less people smoke these days, but more people vape, including some who have never smoked. And so they have now addressed that. They've said that there isn't the evidence for vaping to have its own category, but we should prioritise alternatives to combined hormonal contraception for people who vape. And I think that's the sort of thing that may have to just be addressed opportunistically in practice, because I'm not sure that vaping is always coded. So it may be a question of sending out text messages to people as you're doing repeats for combined hormonal contraception, saying please let us know if you vape, or when people come in for reviews and picking this up opportunistically. But it's only prioritise alternatives. It's certainly not as strong as a 3 or 4. And this phrase prioritise alternatives to CHC has also been added for sickle trait, which wasn't featured before. So sickle disease has always been featured, but not the trait. Then there are 2 multiple risk factor sections, one of which has been updated. So there's multiple risk factors for cardiovascular disease and multiple risk factors for venous thromboembolism. And of course, there is a little bit of an overlap because some risk factors are risk factors for both, but there are also ones that are specific, such as immobility as a risk factor for VTE. So if your patient has several risk factors, then you'd need to look in that section. And that does, I suppose, bring on a little bit of a discussion about what you do if a patient has more than one risk factor. Does 2 + 2 always equal 4 if you've got 2 UKMEC2s? And the answer is probably not. They do say that they're not necessarily additive. So 2 UKMEC risk factors doesn't necessarily equal an absolute contraindication. You'd want to look at whether they were in the same area. So if one risk factor was for venous thromboembolism and one was to do with breast cancer risk, then you'd be less concerned than if you had 2 in the same area. But if you've got 2 UKMEC3s, then that is probably the point at which you might be thinking that the risks really do outweigh the benefits. And then there are some smaller updates. The hypertension section has been brought in line with NICE and has home and clinic readings, which are useful. The section on women who have had breast cancer has been updated to make it clear that when it talks about current treatment for breast cancer, that doesn't only include acute treatment like post-surgery or chemotherapy, but it also includes that longer period of time when you're taking tamoxifen or anastrozole. So that's quite a long time that you need to think about. There's been a shift in the HIV section towards person-centered language, so talking about whether you're well or unwell and on treatment or off treatment rather than CD4 count. And a little bit of a change in the section on sexually transmitted infections. So that mainly affects intrauterine devices, and it's been updated to include Mycoplasma genitalium and to simplify the classifications, and also to include the addition of high-risk HPV within the section for cervical intraepithelial neoplasia seen on smear tests. So obviously we now are much more likely to know if our female patients have high-risk HPV because it might have been seen on their smear test. There used to be a UKMEC3 for continuation of the levonorgestrel intrauterine device, what we used to call the hormone coil or the intrauterine system, for those who've had a stroke, but it's now clear that actually there's no evidence of harm. So that is helpful, that someone who already has a levonorgestrel IUD in place and they've had a stroke, they have one less thing to think about. They don't have to have their contraception changed. And then probably finally, the other big change is that depression and anxiety have been removed from the UKMEC. So they used to be in there, but it was all UKMEC 1 for everything. And now that has been removed. And instead, they have published a separate statement about depression or anxiety, because it's something we get asked about a lot, particularly whether a method might make someone have depression or anxiety if they didn't have it before, or whether it might worsen pre-existing mental health issues. This statement basically says that there's not really any clear evidence that any form of hormonal contraception does worsen or improve mood. And most of the evidence is from observational studies, which always have issues, like they have confounding factors, and they often don't look at women who already have pre-existing mental health conditions. But we know that some women do report mood change during the use of hormonal contraception. So basically, we should, as we always do, take the holistic view. If someone does report mood change, take a history, explore other factors that might contribute. And if the patient really feels that their mood has been affected by the contraception, then think about changing it. And I think that's pretty much what we would do anyway. The only real change from that is they say that patients with pre-existing anxiety or depression should monitor their mood when starting hormonal contraception. And I'm not sure if that's something I routinely told people before.
Yeah, so that's interesting. That sounds like a fairly substantial change then, the anxiety and depression bit.
Yeah, I think specifically for with people with pre-existing anxiety and depression, just telling them to keep an eye on their mood, but it's probably a sensible thing to do.
So obviously there's talk of protection against venous thromboembolism and of protecting bone. What are the other key risks that UKMEC is concerned with?
That's absolutely true. So VTE is a big issue, and bone is something we think about. Cardiovascular disease in general, so arterial disease as well as venous disease, is another big one. So heart attacks, strokes, and things. And of course, the magnitude of the risks has to be weighed up against the severity of the complication if it happens. So, for example, migraine with aura is a UKMEC 4 for the combined pill because of the slightly increased risk of stroke. The absolute increased risk of stroke with migraine with aura is really tiny, but because what is usually a young woman having a stroke would be such a disaster, the combination of the severe effects of the side effect with the relatively small absolute risk means that it's a UK4. And then in terms of other categories, breast is an issue, and sort of gynecological cancers in general. So there are categories for things like we talked about already, current breast cancer, past breast cancer, family history of breast cancer, being known to have a BRCA gene, and then also the other categories of hormone-dependent cancer and of gynecological cancers.
So we've touched on this a little bit already when we were talking about MS, but what are the implications of these changes for GPs? Will you have to do a lot of chopping and changing of people's contraception?
Yeah, it's going to be interesting to see how it plays out. I mean, they did say at the conference when it was launched that obviously it is going to take time for this to bed in because just the numbers are so absolutely huge. There is also the slightly sort of added complication just in terms of getting your head around it, that some methods have a different UKMEC number for initiating it or continuing it because the risk is higher of starting something, but once it's in, the risk is lower, or possibly the other way around, that if you have started a method and then something develops, then perhaps you should stop it. So that one, for example, applies to migraine without aura with combined pill or any form of combined hormonal contraception. It's a UKMEC 2 for initiation, but a 3 for continuation. So if you start to take the pill and then you suddenly get migraine, then that is a little bit more concerning than if you had migraine without aura before taking the pill. An example of the other way around is for those who are unwell with HIV and not on medication. They are a UKMEC 3 for having a new intrauterine device fitted, presumably because of the risk of pelvic infection if you're immunocompromised. But if they have one already, then there's no need to take it out. It drops to a UKMEC 2 for continuation. So in terms of how practices organise this, obviously practices have changed a lot, I suppose, since the last update. We have lots of new staff. We have pharmacists and nurse practitioners working in primary care, probably more than we did in 2016 when the last new one was launched. And we have a lot of allied health professionals who have a specific interest in women's health. So every practice will work out differently how they run it. But I think if you were looking to try and review everyone, ideally before they had their next depot, or at least before they had the one after that, and then opportunistically reviewing, trying to think about it when you're signing repeat prescriptions, electronic prescribing. I mean, I know people will be possibly shouting at the computer and going, that's completely unrealistic when I've got 300 prescriptions in front of me. And I completely understand this, but just if you can, in some cases, particularly if there's someone who maybe you know and they have an issue. And then, of course, being aware of it for new prescriptions, and everyone on combined hormonal contraception should be being reviewed annually. So we will be picking up anything there as well. And of course, these days, patients are often more aware of updates to guidelines than they were some years ago because of the internet. So it may be that some patients will approach the practice and say that they wonder if they should change their method.
And what resources are available to help GPs navigate these changes?
So the co-SRH page on the UKMEC, as well as having the actual full document, it's got a summary table and it's got a 2-page summary of the changes. So that would be a good place to start, and maybe to put that on the agenda at a practice meeting and just go through that 2-page summary to make sure that everyone is aware of it. Co-SRH members can also put in an evidence request to the Clinical Effectiveness Unit. This isn't so much about getting your head around the new UKMEC, but if you come across a patient who has something unusual that isn't covered in the UKMEC, then you can put in a request to the CEU and they will look at what evidence there is and try and give you some advice. They won't tell you what to do, but they'll tell you what the evidence is, and then that is something that can inform your decision making. We've written a document at the Primary Care Women's Health Society, which is on our website, again summarising it, and so I think those are probably the main resources that are available to practices, as well as of course anything locally that's being done, so local federations or ICBs may be putting on talks or webinars or so on.
That sounds really interesting, that you can contact the Clinical Effectiveness Unit about the patients who don't fit neatly into categories or who are perhaps a bit complex. But did you say you have to be a member of the organisation to do that?
Yes, you do. So the co-SRH has an absolutely huge amount of information on its website that is free to access, including all of their guidelines, which are really useful. But they do have a few things that are behind a paywall for members. So that's basically anyone who has the diploma of what was the faculty and is now the college, and who has paid to keep up their membership, which I think is not hugely expensive, and I do find all their resources really useful.
Great. It's been a number of years in between the changes. I think it sounds like it's timely that it's happened now.
Yeah, absolutely. I think it's something that, us who have an interest in contraception, we've all been quite looking forward to it and interested to see what the changes were. So it's nice to have that updated document and to be able to feel that we're sort of using the most recent evidence when we're prescribing. So it's great. And I can only thank Rebecca Strauss and her colleagues at the CEU, at the co-SRH, because I know what an absolutely massive piece of work it has been updating this, and it's really useful to have.
Brilliant. Okay, well, thank you so much, Toni, for joining us on today's podcast, and it'll be really useful for our listeners. And I think you're going to write a guest blog for us about this topic as well. So we'll look forward to that. And thank you very much for listening. This episode was produced by Jude Owen. Don't forget you can claim CPD certification for this podcast if you head over to the MIMS Learning website at mimslearning.co.uk. And do join us next week for our next episode.